Thank you for your kind introductions. And also thank you very much for the honor that you bestowed upon me to be able to talk to the team that is here today on the implications of rolling out primary health care in resource-limited settings in a place like in Kenya. So that is the outline of my presentation. I will talk about alma mater in a very brief way and how PHC has evolved over time. And also how it has evolved in Kenya. And then I'll focus on Kenya, particularly on the key indicators and the paradigm shift, and then the Kenyan PHC model and what has come out of that, and then the lessons that we've learned. Alma Ata Declaration in 1978, before the phrase health for all, global health was centered around more targeted and disease-specific efforts. And this is also same for Kenya. Kenya attained independence in 1965. And therefore, in 1978, Kenya was only 13 years old, so to be specific. Of course, there were failures of disease-specific campaigns, which were there before. And then the recognition of the social determinants of health started to pick up. And there were so many other factors that really led to this health for all to have failed. And therefore, in 1978, there was a shift from disease-specific programs to a more comprehensive, preventive, and primary healthcare approach, aiming for universal health coverage, being led by WHO. And that is what led to the Alma Ata Declaration of 1978, which defined primary healthcare as the key towards achieving health for all at that particular time. So what is primary healthcare? Primary healthcare, according to WHO, in its definition, is essential healthcare based on practically, scientifically sound, and socially acceptable methods, technology made universally accessible to individuals and families in the community through their full participation at a cost that the community and the country can afford in the spirit of self-reliance and self-determination. This is the definition of primary healthcare according to WHO. And it raises several issues that are important, particularly for those of us who are involved in the space of rolling out the primary healthcare, the practicality of it, the fact that it has to be scientifically sound, it must be acceptable, particularly the methods that are used. The technology must be universally accessible. We'll see the type of technologies that Kenya is trying to pick. But more importantly is that the community must participate. And of course, at a cost that the community and the country can be able to afford. But the goal of primary healthcare is health for all. That is in 1978, by ensuring everyone can access essential health services without financial hardship. The first goal, of course, with the ultimate goal is to universal health coverage, to provide essential health services to all individuals and communities, meeting their needs without causing them to suffer any financial hardship. And the key words are the 4 A's: the affordability, accessibility, acceptability, and the availability and high quality health for all. So these 4 A's are directly linked to the primary healthcare definition of WHO, because when you talk about affordability, it comes at a cost. Accessibility, it means it has to be acceptable, and this is where the community comes in. So these are the backbones for the primary healthcare specifically. So what are the components of primary healthcare? Primary healthcare expanded the concept of healthcare to beyond just hospitals and doctors. Previously, before 1978, the healthcare was based at the hospitals and also being led by doctors. And I think the doctors have always taken this to be their space, to include factors like human rights, which were not there before, equity, and community participation, with key 8 essential components, which are very important for the rollout of primary healthcare, not just for Kenya, but for any country, particularly in resource-limited settings, to think through. One is the health education. Of course, health education goes beyond just on health, on the prevailing problems, but also to include their prevention and, more importantly, promotion of healthy lifestyles. Presently, the challenges have changed because of the lifestyle. Then promotion of food supply and proper nutrition, adequate supply of safe water and sanitation, because when we don't deal with wash, then we land in other bigger problems that are waterborne diseases, maternal and child health care, including family planning, immunization, prevention and control of locally endemic diseases, and then treatment of common diseases and injuries, and finally, provision of essential drugs. Most of the facilities, particularly in our setup, may be having challenges to meet all these 8 key components of primary health care, particularly the latter one, the provision of essential drugs. But the PHC has been evolving over time. Previously, as you can see in that slide, we were talking about hospital-based and then doctor-based. But 1978, there was this primary health care, which was pushed by WHO, which changed by the year 2000 to Millennium Development Goals, where we were looking at the goal number 4, 5, and 6, in reducing child mortality, improving maternal health, and combating HIV, AIDS, malaria, and other diseases. And by 2015, we moved to post-MDG towards Sustainable Development Goals, looking at goal number 3 specifically, although other goals are equally important, particularly goal number 5. But goal number 3 looks at good health and well-being. So you can imagine, in 2015, we have reverted back to what we should have started to do effectively in 1978. And that is the dawning of the PHC in Kenya. That after the declaration, and Kenya is a signatory to this declaration that took place in Almata, a lot of things have happened. That after that, we developed the policies that are needed. We went ahead and made sure that all policies that are required for implementation of primary health care were in place. You can see even in 2005, the National Health Strategic Plan 2 included the formation of community health units. We have the Kenya Health Policy, which runs from 2014 to 2030, again flagging out the importance of primary health care. We have the health strategic and investment plans, the medium-term plans, the community health strategy, which runs from 2014 to 2019. We had recognized this. And then we participated in the Astana Declaration, and Kenya renewed the commitment towards PHC. All through all this, we developed the necessary tools, but there were a few tools which were missing, which are practically important for countries that are moving in this direction, especially the least developed countries. One is the political commitment that came in 2023. And if we had done better, we should not have wasted 47 years of beating around the bush and going back to what we should have started in 1978 and picked it up from there and ran away with it. So coming to Kenya now, Kenya is a country which is it's a least developed country among those countries that are yet to develop. We have 47 county governments, which are distinct but interrelated. So in total, we have 48 counties, 48 governments, but 47 decentralized government. Based on the constitution that we passed in 2010. We have an estimated population of 52 in 2025, with a GDP per capita of $2,000 by the end of 2024. So we can see we are not very rich. And the total expenditure on health as a percentage of GDP is only 5.4%. Kenya went ahead to commit itself to the Abuja Declaration, but we have been unable to push our expenditure on health to 15%, which we committed some years back. Our life expectancy at birth is still low at around 68 years, but this is now changing because of the fact that we have tried to manage some conditions like HIV. And then maternal mortality rate is still high, and under 5 mortality rates is also equally still high at 41 per 1,000 population. So there was this paradigm shift towards accessing PHC, moving from the curative state towards the preventive state, moving from non-comprehensive vertical services, which have been running in Kenya for many years, towards comprehensive and integrated services, moving away from fragmented PHC structures towards strengthening the service delivery, particularly at level 3, 2, and 1. And I'll come back to that to show how we have managed to push this so that we now have a model that goes around in that particular area. Then we are moving away from non-sustainable financial support that is taking place towards sustainable financing, with the ultimate goal of enhancing preventive and promotive care to reduce the demand for healthcare commodities. So what did the country do towards this? We had to look, apart from the policy direction which we had taken earlier, that we never moved an inch, we now anchored those policies in law. So we institutionalized this and we developed regulatory frameworks to support universal health coverage. The first one, which was a major milestone in Kenyan context, is the Primary Healthcare Act, which came into force in 2023, that promotes disease prevention through primary care networks. We'll come back to that to understand what we mean by that. Supported by the social health insurance and anchors primary healthcare fund for levels 2 and 3 operations, that is dispensaries and health centers. Beyond that, we also signed in 2023 the Social Health Insurance Act, which, coupled with the Primary Healthcare Act, really moved towards regulating the provision of social health insurance to promote the implementation of UHC, that is universal health coverage, so that all Kenyans can have access to affordable and comprehensive quality health services. The Social Health Insurance Act created the Social Health Authority. And in that health authority, it runs 3 key financial mechanisms for the health sector. One is the Primary Health Care Act, care. So it puts money for levels 1, 2, and 3. Then we have the emergency and the chronic diseases, which is a separate fund for the emergencies, for the chronic conditions like cancers, kidney problems. And finally, it also put in place the Social Health Insurance Fund that all Kenyans are mandated now by this law to contribute towards. And this is a transformation in the healthcare financing in this country called Kenya. And then we also passed the Digital Health Act in 2023, which really looked at improving efficiency and convergence convenience so that we can improve accountability, service delivery, and integrated health information system. We did recognize that without a digitized system, we cannot be able to do things the way we want to do. And then finally, we developed this Facility Improvement Financing Act, which now ring-fenced funds that are collected at the level 1, 2, and 3, so that each facility can be able to retain the resources that they have collected and plow back those resources to improve the services that are there. And that goes to the political commitment that the Ministry of Health, the minister himself, in April of this year, committed to do several things, which are actually 10. Digitization, distribution of computers and tablets, training of healthcare workers on digitization, establishment of what we call smart primary care networks, which I will come back to, developing health exchange, this is digitization still, building and maintaining electronic health insurance claims platform, which relates to the Social Health Insurance Fund, and then implementation of pharmaceutical information and logistics system. This is one of the places where we have basically failed for long because our commodities have always been pushed to those particular levels, leading to a lot of wastage and sometimes expiries of very expensive medications because we are unable to manage our drug orders, and of course, implementation of drug management system, and then the national emergency response, and then finally, the implementation of the telemedicine platform so that services can be brought closer to the people at the periphery. So what do we mean then by dealing with primary healthcare? We develop the community health units, and in each of these community health units, we have a population which is about 5,000, with 10 community health promoters. So each health promoter looks at about 500 people, which is about about 2,000 people are being dealt by one community health promoter. So in each community health unit, we have 10 of these health promoters. And then in one health unit, we have about 1,000 households with one community health assistant who the community health promoters are answerable to. The community health promoters work at the community level, that is level 1, but they're answerable to the community health assistants. And then we have about 100 households per community health promoter. This has now taken off, and the country has about 12.2 million households with 9,500 community health units, which will cover the whole country. And of course, the workforce includes 107,000 community health promoters, bulk of them being female, 70%. And we know why. It's because we are working at the community level, and women seem to do this very well. The coverage right now is supposed to have gone up to 10,000, but the functionality is another different thing that we'll come to. And then, of course, the community health assistants are about 4,700. So we are still doing at around almost 50%. So this is the model that the Kenyan government has come up with, where we have the smoke and the hubs. The hub being the level 4. This is the sub-county hospital. And below the sub-county hospital, we have the level 3, the health centers, level 2, the dispensaries, and level 1, which is the community. So all these are the spokes for the hub. And within the hub, we have a multidisciplinary team that goes around these facilities to support those facilities, to treat patients wherever there is need for that. And of course, by so networking, we are also creating the avenues for referrals so that patients can have comprehensive care. That is how it is. And of course, this has to be governed in one way or another. So we have a primary care network, which is the administrative health unit established to improve access. We have in the governance structure, we have the county primary health care advisory committee made up of 11 members. Then we have the multidisciplinary team, which is the team that goes around, being led by a home family physician. And then the third team is the primary care networks committee, which is really a combination of everybody and anybody who is involved in the healthcare provision at the community, at the primary care network level. So once these systems have been put in place, we anticipate to see a number of things change, including reduced workload, clients being identified, increased investments in primary care networks, smart PCNs, which I said I'll talk about, data utilization for decision making at those lower levels, increased access, and improved quality of care. So there are about 10 things that are anticipated. So if you look at the way things have progressed since 2023, when the law became active, we've now established about 324 community health units beyond the expected 315. So the reality on the ground is that when the country was mapped by the different county governments, they realized that the number of PCNs that was needed is 324. But at the planning stage, it was 315. But fully established is 248, which is about 70%. And the rest are still going on. We have about 65, which are yet to start. So you can see that there has been a cascade in the last 2 years that the numbers are increasing every other day. The lower piece of that slide tells you that for each county, how many community health units have been formed, how many are active, how many are yet to be formed. The red ones are the ones which are yet to be formed. So when you see a green bar, it means completely that is already established. So there has been good progress so far, that at the moment we are doing more than 70% of establishment. And once we have the places where we've established these community primary care networks, we've increased the coverage up to 87%, and also the deliveries have increased up to 98% in some areas. Now, these are major issues in the healthcare setting of a country like Kenya, because some of these places have the highest infant mortality rate. Like, for example, Garissa as a county has the highest infant mortality, maternal mortality in Kenya, which is over 700, and that is the highest. So you can imagine that this is now being addressed through the primary care networks, because the deliveries now are happening in the facilities. We have innovations which have taken place. For example, we are now using drones for supply of some commodities and portable ultrasounds, which are being tested in one of the counties called Kwale. The outreaches, the elderly are being reached, which was not happening before. We have improved referrals through the coordination of the multidisciplinary teams, increased facility-based outreaches, because the multidisciplinary teams are the ones which are going around, and as they go around, they are definitely improving on the outreaches. So we are bringing the services closer to the people, and people don't have to walk for long distance or even to miss out. They can just wait for these teams to come. And of course, there's been an increased community screening. Looking at the community itself, in terms of community health units progress, you can see the transition. Unfortunately, I was not able to do the calculations in terms of proportions to make a lot of sense, as based on what we're anticipating to achieve. But you can see that the number of people who are being reached is far beyond what was happening before. For example, we've had more than almost 28 million screenings for diabetes, which is being done by the community health promoters within the last 2 years. And we've had almost 326,000 referrals for those who at the community level had signs and symptoms that could be diabetes. I did not cascade that to see how many of these turned out to be real diabetics, but you can be sure there are quite a number of them, which means that there were people in the community who were sick, but they could not be picked. But with the primary care network being rolled out, the community health promoters have been able to screen people using symptom screen, including hypertension, including any other condition that is of importance at that particular level, because the community health promoters have a guide on what is expected of them and how they are expected to work at that particular level. We've also put in place a community health information system, which is called ECHIS, which is Electronic Community Health Information System. This system is now being rolled out. And you can see the weekly report of September 2025, which is about a month and a half ago. The people who have been enrolled by the community health promoters into the system is really growing exponentially. The number of households which have been registered, because the community health promoters visit each home. The maternal and child health impact, as you can see there, the number of pregnant women who have been identified has gone up. These are some of the mothers who would have ordinarily delivered at home. The number of children who have been assessed for malnutrition and other diseases, 10 million plus. These children would have continued to suffer in the community without the involvement of the community health promoters. And of course, these people need to be remunerated. And that is one of the biggest challenges that is now facing us as a country, because we have more than 100,000 community health promoters to cover the whole country. This was not initially budgeted for. And the way the system of the country is such that at the national level, the money is appropriated and dispersed to the counties. Now the counties, because the healthcare delivery has been devolved, are expected to recruit these people and put them on a stipend. You can see a number of the health facilities, a number of the health of the counties have not really enrolled these people and fitted them into the system. And therefore, there are still challenges there that we think needs to be addressed. And these are some of the things that will be looked at even as we go ahead. There is a lot of economic and health gains from the PHC investment. Economists who have done the work in Kenya have realized that for every Kenya shilling one, which is invested in primary healthcare, we save about 16 shillings in healthcare costs, and that is a major way of saving money. We are shifting 70% of healthcare services from high-level hospitals to primary care facilities, saving over 192, almost 200 billion Kenya shillings in the next 5 years. The investment averts 64 million disability adjusted years, because people are able to be reached much, much earlier, improving, of course, the workforce productivity. We are preventing mortality and morbidity, which has been avoided. And you can see the number of deaths which have been averted in the last few years. The cost of inaction, without this process being put in place, then we could be losing an equivalent of almost $230 billion by the year 2030. So it makes a lot of economic sense that this is already happening. We have learned a number of things. One of the key things that we've learned is that there must be political commitment if you have to have any progress, because the political commitment will address issues of resources, issues of policies and the legal space. It will address the governance structure, because everything sometimes becomes political. So political commitment is very key, and countries which are moving in this path must affirm the political commitment. Otherwise, nothing will happen. Then the community health promoters must be incentivized, because they are the people who do the job at the community level. This is where the rubber meets the road. So they must be given tablets, they must be given the monthly stipend to incentivize them to work around the 100 households that they are expected to cover within 3 months. The national digital infrastructure is critical, but yet very, very costly. So if you are talking about rolling out the community health information systems, you must be thinking about electricity for the tablets so that you can be able to charge the tablets, link those community to the health facilities, and therefore the health facilities need electricity, they need computers, we need to put in place the wide area network and the local area network, and ultimately create that superhighway, the infrastructure for the data to be moved from one point to the next, with the introduction now of the use of real-time data collection, so that you can even go to very advanced levels of AI to be able to predict what could be happening in different parts of your country. And then, of course, the human resources at all levels must be taken care of. And with that, I submit, Chair. Thank you very much. And I'm now ready for any questions. Thank you.